Welcome to this continuing medical education internet symposium. This activity is jointly sponsored by the Postgraduate Institute for Medicine and Viral Ed, LLC. Support for this program has been provided by an unrestricted educational grant from Gilead Sciences Medical Affairs. This web symposium is being brought to you from the 14th European AIDS Conference in Brussels, Belgium. This symposium will discuss new studies on ARV therapies and therapeutic strategies presented during this conference. After completing this activity, the participant should be able to use in a clinical setting findings from key new studies on HIV/AIDS diagnosis, management, and treatment presented at the 14th EACS. State the current treatment paradigms for HIV/AIDS, including the studies and data presented at the 14th EACS, and use that understanding to improve patient care. Discuss with patients and colleagues the studies and data on newer therapies for HIV/AIDS presented at the 14th EACS, and use that discussion to decide on appropriate planning of therapy for patients with HIV/AIDS. Our distinguished faculty panel for this program includes course director and moderator Calvin Cohen from Harvard University Medical School, and panelists Jürgen Rockstroh from the University of Bonn in Bonn, Germany, Graham Moyle from Chelsea and Westminster Hospital in London, England, and Jose Arribas from the Hospital de la Paz in Madrid, Spain. The Postgraduate Institute for Medicine requires all faculty participating in this activity to disclose any real or apparent conflict of interest they may have as related to the content of this activity. All faculty disclosures can be reviewed here or on the homepage of this program. This activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education by the Postgraduate Institute for Medicine and Viral Ed, LLC. The Postgraduate Institute for Medicine is accredited by the ACCME to provide continuing medical education for physicians. The Postgraduate Institute for Medicine designates this enduring material for a maximum of 1.75 AMA PRA Category 1 credits. Physicians should only claim credit commensurate with the extent of their participation in the activity. Thank you for your time. The program will now begin.
Thank you for joining us. We'll be reviewing very interesting data with you from the 14th European AIDS Conference. This conference had a wealth of data, some very exciting data, new guidelines, new insights, and indeed some studies that were presented here for their first time. I have a great faculty that will be reviewing this data in our CME Internet Symposium, and we appreciate you joining us. First up will be Dr. Jose Arribas, who will be reviewing studies in treatment-naive patients.
Thank you, Carl. I'm going to start with a study, and the name is Gardel. Gardel was a famous tango singer in Argentina, and the lead investigator in this trial is Pedro Can, also from Argentina. So the study is a study of antiretroviral naive patients that were hepatitis B antigen negative, and they were randomized to receive a dual therapy with lopinavir-ritonavir BID plus 3TC BID, or lopinavir-ritonavir and 2 nucleosides. And it's a 400 patients trial, and randomization was stratified by viral loads above or below 100,000 copies per ml. The baseline characteristics: patients had a median viral load of 4.9 logs, and more than 40% of the patients had viral loads above 100,000 copies per ml, and 20% had CD4 cell counts less than 200. It's important to realize that in the triple therapy arm, the nucleoside chosen by the investigators, because they were not provided in the trial, represented what is available in the different countries. So half of the patients in the triple therapy arm took Combivir, and the rest was a mixture of mainly tenofovir FTC and abacavir 3TC. So this is the main result of the trial. This is the proportion of patients with less than 50 copies per ml by a snapshot. And you can see that in the triple therapy arm, the efficacy rate is 83.7%. And I think it's important to point out that that rate of efficacy is what we are used to see in other trials with lopinavir-ritonavir and 2 nucleosides. The efficacy rates in the dual therapy arm was 88.3%. So the trial met the non-inferiority criteria. And also it's important because there was ACT on board. If we look at the observed data analysis that doesn't take into account the discontinuations due to adverse events, you can see overall very high and very similar efficacy rates. Always with dual therapy, there is the question if this is going to work in patients with very high viral loads. So I think this sub-analysis is also important, patients with viral loads about 100,000 copies per ml. And you can see also that the results of the trial are about the same. Patients on dual therapy, 87% undetectable. Patients in triple therapy, 78% undetectable.
I wonder if you could explain this slide to me, because I had trouble when I saw this, because this suggests that adding a third drug reduces your rate of virologic suppression, and I had trouble understanding that.
Yeah, I will be interested in what Graham will say, because we've seen in other trials that the more advanced patients have more difficult tolerating the drugs.
I think that's what it's about, is that it's probably that AZT-related nausea and anemia-related discontinuations that are contributing adverse effects.
I mean, we saw at the World AIDS Conference in Mexico, we saw data where Kaletra plus AZT3TC was compared to a efavirenz-containing regimen in advanced patients, right? And there was a very much lower response rate, and that was really driven by advanced patients and high AZT-related complications.
Okay, good. That helps.
Good point. And if we look at the reasons, because always in this trial we have to be very careful looking at the virologic activity and the discontinuation due to adverse events. If we look at patients with HIV RNA more than 50 copies by snapshot, is very similar, 4.7% in dual therapy, or close to 6% in triple therapy. There were more discontinuations in the triple therapy arm, 5%, and is what you expect with Combivir, is 3 cases of anemia, 5 cases of GI intolerance, so what is expected with ACT. So if we look at confirmed virologic failures, it's very similar numbers, 10 in dual therapy, 12 in triple therapy. Viral loads at failure were in general low. You can see there the numbers, and nobody had a primary PI mutation. Didn't happen in dual therapy, didn't happen in triple therapy. The only difference is that 2 patients developed 184B in dual therapy. No patient developed mutations in the triple therapy arm.
Jose, do you think that difference in rebound is relevant? So, you know, I appreciate it, we're getting down at small numbers, but, you know, a lot of those never suppressed may be individuals who discontinue with a detectable viral load but an adverse event, versus we like to think that once you get suppressed, you stay suppressed, and whether that's a weakness of the dual therapy arm.
Right, could be 8 patients versus 4, so we are talking about 4 patients. So I don't have a good idea of how suppressed they were before they rebounded, but yeah, what could be.
And the patients are going to stay in study, because I think the week 96 is going to be crucial here.
The study is going to continue until week 96, and we are going to see in next conference and analysis also by baseline factors and including the nucleosides. But to me, in general, it is surprisingly good results. With boosted PI and 3TC, we've seen other combinations trying dual therapy.
Isn't it amazing that we're starting to see more and more studies where there's absolutely no resistance after 48 weeks? Taking account that we're taking relatively old drugs, which are not really preferred agents anymore in some of the guidelines. It's amazing to see that if you make your population a little bit earlier, that you can actually improve your results.
Yeah, well, one question, I don't know if you know, is if they did the resistance analysis on the first or the second sample. I'm not sure if you know, because it mentions confirmed virologic failure, but I know that's
I think it's in the second sample, but I can guarantee it's in the second sample.
You know, and the contrast with the Monarch study, where lopinavir as monotherapy didn't achieve induction in anywhere near the reliability, that just adding in a single drug is quite useful in terms of
depending on which drug.
Depending on which drug, because in Monarch was exactly 69% efficacy rate. So the difference that 3TC adds, and I think 3TC is a good idea, long terminal half-life, quite active, and no interaction whatsoever with lopinavir. So we are waiting for NIT-001 with darunavir and raltegravir, and we know that probably that with darunavir and maraviroc, it seems that it doesn't work.
Right, we've got some other studies of 2 that haven't worked out, so this one's been interesting.
Yeah, and we have the rest of the studies are updates on well-known studies. This was an update 3 years follow-up of the comparison between quad and tenofovir FTC atazanavir ritonavir, and that's the 103 trial, and the 102 that is the comparison also of quad with albitegravir and covisistat versus Atripla. And it's important that we have 3 years follow-up, I think, both for efficacy but predominantly for safety that we will touch upon later on. So at 3 years of follow-up, things have changed very little. It's still amazing that with these new combinations, we have almost 80% of the patients after 3 years of follow-up remain suppressed. And when we look at the tenofovir atazanavir ritonavir arm is 75 and Atripla is 75. If we look at these were non-inferiority trials. If we look now at the analysis and we look by a snapshot, when we look at after 3 years of follow-up, obviously quad meets the non-inferiority criteria, both when it's compared with Atripla, when it's compared with Truvada, atazanavir, ritonavir.
Remembering that the patients going into these studies had quite good baseline characteristics, which may be one of the reasons why we see this, perhaps even compared with the previous study with Gardel, where there was more high viral load, low CD4 count patients.
Although in year one, I mean, it's 89% and 84, so it's almost recapitulates what you just showed us. So it's very similar types of numbers.
Yeah, that's important, that point, that these patients have very high CD4 cell counts at baseline. And, okay, in terms of resistance, again, very little action between year 2 and year 3. There were just a few patients. There was 2 or more patients with resistance in the quad arm. And what we expected is to have, we know that when quad fails, one should expect to have both integrase inhibitor mutations and nucleoside mutation, and that's what happens. In the Atripla arm, also just this is extremely low numbers, so the take-home message is that from year 2 to year 3, we have seen very little emergence of resistance. In that atazanavir ritonavir arm, at least after 3 years of follow-up, took 3 years of follow-up to pick 2 patients with 184B.
Yep. What I like about this slide is that it shows you how many patients were viremic for the resistance analysis, and then how many developed resistance for the albitegravir arm. It's about 6% viremic and about 3% show resistance. So it does show that there is some wild type rebound, and then there's some patients who develop resistance, but it's not everybody.
It's not everybody. At the end of 3 years of follow-up, if we add up the numbers, it's 2.2% of the patients had some resistance. So
somewhat reassuring that it's still only a minority of the rebound.
Okay. And then another update in the STAR study. The STAR study is another study of antiretroviral naive patients comparing head-to-head to STRs, Atripla versus Eviplera or Complera. We knew the 48-week data. What has happened from year 1 to year 2? Well, very little. If we look at virologic failures, there is just 1% more virologic failure in the Eviplera arm, 1 more in the Atripla arm. If we look at the main endpoint of the trial, again, Eviplera meets very well the non-inferiority criteria. The point estimate is 5.5 in favor of Eviplera, and it barely misses the 0 for the primary endpoint. If it's important, we know the label of Eviplera, it allows it to use it in patients with less than 100,000 copies per ml. And when we look at this analysis at week 96 after 2 years of follow-up, actually Eviplera meets the superiority criteria as it did during the first year. So when we look at patients with more than 100,000 copies per ml, the non-inferiority is still met with a very small difference between Eviplera and Atripla. It's interesting because we used to analyze trials instead of the snapshot analysis with the TLOBR. I don't think that means a lot clinically, but if people want to know how the trial did, if we analyze it with TLOBR both for the primary endpoint with all the patients included, both at first year and second year, Eviplera was actually superior to Atripla. So in terms of virologic failure, it's important also that if all patients with viral loads above 100,000 copies did equally, and we have really a signal that the higher risk of virologic failure on Eviplera is really concentrated in patients with extremely high viral loads, with viral loads above 500,000 copies per ml. From week 48 to 96, in the strata between 100 and 500,000 copies per ml, still the rates of virologic failures are numerically identical in the triple arm and in the Eviplera arm. It's only in patients about 500,000 copies per ml that is still a sensitive difference between Eviplera and a tripla. So on the other interesting trial, the last one I'm going to comment is the Flamingo clinical trial. This is a subgroup analysis of Flamingo. Flamingo is a study of antiretroviral naive patients who receive 2 nucleosides that 2/3 was Truvada, 1/3 was Kaivexa, plus either dolutegravir 50 milligrams QD or darunavir boosted with ritonavir QD. We saw the primary endpoint results in EACS, and we saw that the dolutegravir arm produced 90% of the patients were undetectable after 1 year compared to 83%, and actually that difference, that 7% difference, met criteria for claiming superiority. So people are quite interested in how both arms perform in different with regard to different baseline characteristics. And this forest plot graph really tells the story. In patients with less than 100,000 copies per ml, both arms did similarly. In patients with high viral loads, above 100,000 copies, actually the point estimate and the confidence interval is really shifted to the right, showing that in that subgroup of patients there was a difference between dolutegravir and darunavir ritonavir in the context of very high efficacy in both arms, but the differences became bigger. The other very interesting question is if the nucleosides did anything differently when combined with these 2 different drugs. There is always the concern about the activity of abacavir 3TC in patients with high viral loads, and you can see that for all the patients that it did not make a difference. With tenofovir FTC, you see there is superiority. The confidence interval doesn't cross 0, but with abacavir 3TC, there are less patients. It's almost half of the patients, so the confidence interval is much wider. So the other characteristics, baseline CD4, gender, age, and race didn't make, the difference were not that big. And if you want to make another twist on this and looking at patients with high viral loads and the interaction between high viral loads and the nucleosides that were used, and we look at patients with more than 100,000 copies per ml treated with tenofovir FTC, we see that the point estimate clearly favors dolutegravir, and the confidence interval shows also superiority. But let me point out, when you look at the abacavir 3TC, the point estimate is even larger. There is a larger difference between dolutegravir and darunavir, but however, because of the small number of patients, just 25 patients, the confidence interval is quite wide. So it doesn't prove superiority, but the tendency for me is pretty much the same. So why, how can attribute the superiority in Flamingo? Were 2 issues. I think if we look at high viral loads, it's both a combination of less virological response in the darunavir arm. There were 18% of the patients in this subset of patients with high viral loads without virologic response, versus 7 in dolutegravir, but there were also more discontinuation due to adverse events in this group of patients.
Mm-hmm. So what I recall is that if this slide was taken then to the high viral load, which is obviously where the darunavir arm is falling apart to a greater extent, when they showed a different analysis, which was protocol-defined virologic failure, which in essence was simply just confirmed viremia, all of a sudden it was 2 per arm, and all of this went away. So obviously a lot of this is single, unconfirmed viral loads above 50.
Right, yeah.
There was no resistance that emerged in either of the arms.
That's right.
And I think it's driven, interestingly, by the poor tolerability in the advanced patients again, which is curious because, of course, the way that darunavir had outperformed Kaletra in Artemis was by performing better than Kaletra in the difficult-to-treat patients from a tolerability standpoint.
Right. But the viral kinetics can also play a role. If you have, in the highly viremic patients, it could just be that it just takes a little bit longer to reach, persistently undetectable. And with a boosted PI, rather than an integrase inhibitor where you get suppression much faster.
The other criticism I've heard is that this is an open-label study, of course, and that therefore people may have preferred to get into one arm than another, and that may have driven the adverse event-related discontinuation as people looked to get onto something else?
I tend to believe more that because this is 48 weeks, a boosted PI in 48 weeks even.
But in very high burden patients,
48 weeks.
Yeah. Well, Laura Water showed us at least one study suggesting it's possible. But
it's possible.
I mean, I think what's striking not how well dolutegravir is doing. It's doing consistently well as it always does. Yeah. It's just the darunavir looks worse than expected. So I think it's more a question of what to do with that.
But if you look at the resistance data, there is no signal of...
Exactly.
No,
so it's not really virologic failure.
Exactly.
It's low-level viremia.
It underlines, that darunavir has only ever been tested against Kaletra in treatment-naive patients in a large-scale study. This is the second time it's gone up in a large-scale naive study, and it's been found wanting.
That's true. Yeah. Well, at least low-level viremia. That is. Yeah. No, I agree. That's what we're observing here. So it certainly confirms how good dolutegravir is for this population. Great. That's very impressive. Thank you. So I'm going to actually take it from here because with this as background to treatment-naive patients, I thought I would take us to perhaps one of the big controversies at this meeting, which was the update from the European AIDS Clinical Society guidelines. So we had an update on two aspects, as we'll always cover in this group, though there were other things that were reviewed, and I do highly recommend to our audience to go online, take a look at the European AIDS Clinical Society guidelines. There's a wealth of information that summarizes the care of people with HIV. So here we're just going to cover really a small subset and those things that were updated this year. The first is the ongoing controversy of when to start, and unlike in previous years, there's no longer a distinction of 350 to 500 versus above 500. You might recall in the past, above 500 asymptomatic, there was a column called defer, and they actually recommended that you not treat. And here it was that is removed from the guidelines, and now it's either consider or recommend. And they had we had a lovely discussion by Nathan of what consider means, and it means exactly what you'd think, which is that there are pros and cons, there are reasons to start, there are reasons why it's okay to wait, and that's what consider was being more permissive. And we now see that anybody above 350 that it's consider, but that we still, in part because of the concern for the lack of data from the START trial, don't know yet enough to say we would recommend it. And there's some controversy since in US guidelines, in the absence of data from the START trial, they would favor recommend therapy as opposed to consider. So it's just what we do while we're waiting in some ways. There's also the consider to reduce transmission of HIV, and I'm not exactly sure I totally understood why that wasn't a recommend as opposed to a consider, other than there are other ways to prevent the transmission of HIV other than through antivirals. He did point out that some of that is a resource issue. If you don't have the resources to use treatment as prevention, that you would consider prioritizing more advanced patients than this.
The European guidelines are always constructed with an eye on the European National Health Services and what they can afford to deliver and pay for, and of course the differences in availability across different European countries.
And it's an individualized patient approach, so really the patient has to benefit. It's not a public health approach like some of the other guidelines, and so it's really if the discordant couple decides they want to be treated for and then that's possible, and that's all in the, so I think that support by the consider very much is possible.
The guidelines make a strong point that these discussions should be informed with all the patients, that they need to know the information that the treatment for prevention works, but it's up to the individual patient that should know that we don't have hard data proving that it's good for the individual, for the person.
Sure, that's fair. The other things on this slide really haven't changed much. It's recommended for people with a number of symptomatic conditions, neurocognitive impairment, and so on. The only group in whom there's still a consider in terms of comorbidities is the uncertainty as to whether high-risk cardiovascular patients would be improved by the addition of therapy, in part because of the ambiguity of how much our therapies would decrease that risk versus not change it at all, or even increase it depending on the various treatments and the controversies around them.
And there's obviously also a recommend for higher CD4 strata for patients with co-infection. Just to mention that.
Yes, thank you very much. Yes, there's an entire chapter on the viral hepatitis. Any more detail, please feel free. So in terms of the initial recommended regimens, I put this slide as the kind of summary of what is here. It's perhaps reasonable to just remind people what's not here anymore. Nevirapine is no longer present on this list, and lopinavir is no longer present on this list. In some ways, the lopinavir made sense because we had trials against the efavirenz. We've already discussed one of them, versus atazanavir versus darunavir, in which lopinavir came in second choice. So it makes sense that the guidelines reflect those clinical trials. And nevirapine was more of a safety issue than an efficacy issue, at least that's what the guidelines do mention there. But rilpivirine co-formulated is there along with efavirenz, boosted atazanavir, boosted darunavir, and raltegravir. The only thing that was changed on the nucleoside is that abacavir 3-TC or tenofovir FTC were permitted regardless of the other drug. There are very few data of abacavir 3-TC with raltegravir, but the guidelines were willing to extrapolate and say either nucleoside with any of the choices. There is the continuation of the footnote of caution with the use of abacavir in patients at high cardiovascular risk, as well as persons with a viral load over 5 logs. That continues to be something to inform the guidelines, as is true for rilpivirine, caution with 5 logs.
Rilpivirine is different to a footnote. It's only recommended in lower viral load patients, whereas the other one is they use it.
Which makes sense because that follows the label.
Yeah, absolutely. And we have some data that you've just reviewed with us that abacavir can do well in high viral load, depending on perhaps what the third drug is.
And we have data from SPRING2, right?
Right.
With SPRING2 supporting the activity of abacavir 3-TC plus raltegravir. Is not huge number, but the tendency was the same that with.
Right, it's supported. So that's where we are in terms of what was recommended. Then we take a look at what's listed still in alternative. It's no longer done by regimens. It was really done by regimen components, so it's not a column A, column B approach. For the nucleosides, it was a little surprising to me to see that DDI is still there, though there is a comment that that's only for patients in whom there's either nothing else available or intolerance to others. I don't know how often that's the case, but DDI 3-TC and DDI FTC continue to show up in the same place as is tenofovir 3-TC, which is, again, a little surprising. Zidovudine 3-TC, of course, is still there, and that makes sense. But the DDI thing is a little bit surprising, but there it is. For the non-nucleoside, we've already talked about nevirapine, and the safety caution language is there on this slide in terms of the CD4 issues. Ritonavir boosted PI, we've already mentioned that we've got the lopinavir joining fosamprenavir and sequinavir, which again makes sense. There are head-to-head trials of lopinavir versus either one showing essentially similarities there. The integrase inhibitor of elvitegravir cobicistat remains here, and what's interesting is, I guess, the European label, how it differs from the US label, in which there's now a recommendation to be cautious with GFR less than 90. In our label, it certainly reflects the study, which is less than 70. This is an additional caution here that seems to be even more conservative.
That's the first time that compound has been in the guidelines, but it's not clear where the evidence base for that caution has come from.
Yeah.
It's in the label, but we don't know why, exactly why.
Right, so this more reflects the label rather than kind of a vote of, kind of an additional vote of concern. So it's a little bit confusing because this number doesn't show up in the studies as a caution. And as you just presented to us, elvitegravir cobicistat has been non-inferior for 3 years to 2 regimens on the previous slide without any safety signal.
We comment also with a lack of data in a very important population in patients in Europe. There is advanced patients. In Madrid, we see patients with 20% of my new patients have CD4 cell counts below 200. That is one of the scenarios where with quad doesn't have a lot of data.
I see. Okay. So perhaps in future studies we'll get more information about that particular subset. And then Maravrox still appears here, just kind of listed. It's actually noted, I think, that it's not indicated for naive patients, but it was listed here as well. So ongoing discussion, ongoing controversy about these guidelines. I think certainly probably the biggest controversy was the placement of elvitegravir cobicistat, which, as you point out, is here for its first time. It's certainly the U.S. guidelines also have it here. I think there's a discussion in the U.S. as to whether, based on the studies you just showed us, if it warrants moving up.
Yeah, clearly the efficacy data is very robust. It's just, as the U.S. guidelines comment on, the drug-drug interaction data could be improved upon,
right?
And the long-term renal safety data, remains an open question at the present time.
Although the drug interactions are the same as ritonavir boosted atazanavir or darunavir, so in theory it wouldn't be worse than those.
But I think that a lot of new data has been presented at this meeting.
Yeah.
I'm sure that when more drug interaction studies have been completed, that all is going to change. And remember that there has been a recent presentation of the more specific renal issues in the 102, 103, looking at all different kind of renal markers and really showing that after week 24 there has been no case of proximal tubular damage in any patient in this trivalent arm and so forth. And I think that's going to help.
That's fair.
Because I think, with all the other drugs available, you want to be sort of safe and take maybe a more conservative approach. But I guess if more data comes and a lot of trials are ongoing, I'm sure that will be discussed.
Yeah, no, that's fair. And actually, Professor Klumek did mention from the podium that this is always a work in progress, and that's where they were when they reviewed the data. But as you point out, new data have been presented even after these guidelines were written. So that's a fair point. So I thought in my section I would then highlight really kind of two key issues. One is the abundance of switch studies in treatment-experienced patients. Since we rarely have viremic patients going on salvage, the dolutegravir data on 50-BID has been shown for years. We saw another version of it here, but really there isn't a lot for the viremic failing patient, but there are a lot of switch studies. So I thought I'd highlight one of many that have been done, only because it's novel and we haven't reviewed it. This is a study from France, from Nantes, and this is the study that was called SWING. The study was because for having to do with a switch in nevirapine, and the G is just from virologic. But the study design is very simple. It's patients who are virologically suppressed on tenofovir, FTC, and nevirapine. 80% of the nevirapine used was once daily, and the patients were virologically stable for at least 6 months with virologic suppression. No reason to suspect underlying resistance based on no previous history of failure, a proof of either a lack of resistance by genotype or current DNA, and of course no PPI used because the design was to switch from nevirapine to the co-formulated tablet of tenofovir, FTC, rilpivirine, or Eviplara, as you described earlier. The percent of suppression at week 12 was the primary endpoint, with additional follow-up to week 24, and a number of secondary endpoints that I thought were interesting for this particular presentation. This is who enrolled. They enrolled 32 patients, and you can see here there's really no surprise other than these patients have been on therapy for 7 years, on this regimen for 4 years, with ongoing virologic suppression for many years, with good intact CD4s, as shown here. As I mentioned, 81% were on once daily nevirapine. So it's not too surprising that at week 12, their primary endpoint, that essentially all patients on therapy continue to show virologic suppression. Not surprising. If nevirapine is an active drug, rilpivirine should be an active drug. The only thing that happened is that one patient discontinued the arm due to insomnia on switching to rilpivirine. Not something that we saw much in ECHO, THRIVE, or in STAR, but certainly things happen in studies that don't always fit. At week 24, they did report that there were a few other patients who switched. A few people switched back because of the food requirement of rilpivirine, so there were 2 who switched there. And there was one blip of 91 copies at week 24. They pointed out that that person was suppressed at week 28. So that in terms of virologic, not surprisingly, it worked, and there's certainly no surprise. What was presented, though I decided to just describe it, was the PK that supported why this made sense. Just as with the efavirenz, there is induction of nevirapine on rilpivirine exposure. For the 1 week that nevirapine goes from present to absent, rilpivirine exposures go from low to adequate. And you see this kind of beautiful PK line that supports
I thought that disappearance of nevirapine was really quite quickly in the study. It's very different to the tail of efavirenz that we're used to.
Yes, so it's a good thing that kind of the effect of the nevirapine allows those enzymes to then stop working so that you get the adequate rilpivirine exposure. So it works out well in these studies for going from one non-nucleoside to another. I thought this was are you
going to show? Yeah. You're not going to show the quality of life?
I am. I'm going there next. So thank you for presaging where we're going. We're going to show 2 more things. One is the food slide, and then the quality of life data. So as we all know, rilpivirine requires food, and the studies have been done with at least 390 kilocalories or more. And so in this particular study, they then inquired with a nutritionist what was the calories at that meal to get a sense of how well patients are doing. What I found interesting, again, this is a French study in Nantes, is that for breakfast, almost 20% of the meals had either less than 390 calories or less than 2 grams of fat. Now, our label doesn't mention fat, and the Canadian label don't mention specific caloric requirements, so I'm not sure where the 2 gram of fat requirement was coming from. But nevertheless, this study supports that perhaps in France, breakfast is a smaller meal than either lunch and dinner, where the meals were perfectly adequate. I know in other countries, breakfast is a big meal. Certainly in the U.S., our breakfasts tend to be pretty generous.
Yeah, with those standardized meals that the FDA use, they all contain about 30% fat and a similar proportion of carbohydrate and protein, so that you can't actually decide which is the component of those meals, apart from that they did this with a nutritional drink and showed that you couldn't have a nutritional drink that did the job. It had to be solid food in some way, and a coffee and a cigarette is not sufficient at breakfast.
Neither of those would be considered food in this study, that's right. One more point, they also then presented a very nice plot of the calories of the meal and the exposure by C trough rilpivirine, and you can see it's pretty noisy. there was no consistent relationship, perhaps supporting the fact that while we talk about a 400 kilocal meal, it may be that there's some patients who have less than that, who have more than adequate exposure, as there does appear here, and there's certainly kind of a very wide range of exposures at a wide range of meals.
And I have to, and everybody was suppressed, and probably when you are suppressed, probably the consequences.
So there's one other interesting thing that was presented by Francois, which is that in this presentation, patients who went from 3 pills a day to 1 pill a day had a surprising report that even that small change, almost 90% said, this is better, I appreciate this. Of course, these are patients who entered a study to switch, and when they switched, they liked it more. So it just reinforces us that the small changes we make can be appreciated by a large majority of our patients. And the few patients that didn't like it said it was really just the requirement to take something with food that they didn't like. It was nothing about the pill itself. So that was just kind of a helpful little piece on treatment satisfaction. The last study I thought I'd present, which was the first presentation of a clinical trial called LATTE. LATTE is one of the first studies we have seen now using the new integrase inhibitor called 744 in combination with 2 nucleosides versus 2 nucleosides with efavirenz. As you can see, it's a dose-ranging trial. We've seen these 5 milligram and 30 milligram in phase 1 studies. This is now a phase 2 study that gives us a broad range, including going up even higher, all the way to 60 milligrams. The design is simple. Treatment-naive patients are randomized across the 4 arms. And as you can see, this is a 24-week time point of this particular randomization. At week 24, the patients will then be optimized to the best dose, which we were told was chosen as to be 30 milligrams based on the data we're about to review. All of this is kind of a presaging towards where this is going, since we've talked about the fact that both 744 and rilpivirine have long-acting parenterals, and this study is the first step towards looking at 744 and rilpivirine either orally, as you can see there in the green bars, or if the oral goes well, a parenteral approach that would be a follow-on from this. So let's take a look at these data. This is the baseline characteristics. It's certainly well balanced across the studies. You can see the viral load was rather low in this study, around 4.3 log on medium, and the CD4 is around 400. Otherwise, you can see here the usual breakdown. About 2 out of 3 patients are on tenofovir FTC, the other third on abacavir 3TC. In terms of the disposition by week 24, that right column of 744 really summarizes it, and there wasn't much difference in the 3 doses of 744. Very low rates of adverse event leading to discontinuation for 744, and the usual 11% on efavirenz, although that happening by week 24 is perhaps a little bit higher than some, but it's a small arm of 62 patients. Otherwise, you can see essentially nothing particularly different between the 2 arms of the trial of the 744 or efavirenz, a small number of people with various criteria, but overall, people doing pretty well. And indeed, if we take a look at the usual snapshot approach, we can see that about 87% on 744 do achieve less than 50 copies by week 24. 74% are there on efavirenz. We know that efavirenz can take longer, though the viral load is lower here. Most of that difference then we can see in terms of breaking down, is it virologic or adverse event? It's not virologic. You can see that there's about a 6%. Well, let's take a look at the first part. The data in window not less than 50 is 4 and 5%. So you can see it's really discontinued for other reasons while not less than 50 copies. That's where the predominant is. That's usually, it can be an adverse event dropout on the way down in the first 24 weeks. In contrast, we can see the lack of virologic data at week 24 is predominantly a 6% increase in adverse events. That's listed right here.
So how long the patients have to be suppressed before they are switched to the to rilpivirine and 744?
So the decision is actually based on the week 20 viral load. If at week 20 the patient was less than 50 copies on 744 and 2 nucleosides, at week 24 they then make the switch to rilpivirine plus 744 instead of 2 nucleosides in 744.
So this is basically an induction maintenance
Exactly.
study. So I wonder why they don't request a fixed period of undetectability individually instead of, making...
Yeah,
well, it will be safer.
Yeah, well, it'll be interesting to see if they get away with, in some ways, just at least a few measurements.
Yeah, the 2 studies that have done this before with the Induma and ARI studies, where they dropped ritonavir out.
Yes.
And one was a Glaxo approach that just used the 24 cutoff, and the Bristol Myers Induma study used consecutive undetectables. But the outcome of the studies didn't really differ a whole lot. So.
That's true. So we'll see. We'll see if this is successful, because obviously that's the question that they're addressing in this study.
Because this is a drug that's similar to dolutegravir. Yeah. So the question is, are you de-intensifying the genetic barrier by dropping the nucleosides? And,
right. Well, you're going from 2 nucleosides to rilpivirine, which certainly does seem like a difference in the genetic barrier, but we'll see if it's enough to maintain suppression. That's the question.
And you're saying they're moving forward with the 30 milligram?
So yeah, I'll show you that in a moment in terms of why, because obviously efficacy looks very similar here. Yeah. It's really the safety that we'll get to in the one slide. The only thing to point out, in terms of the efavirenz virologic failures that you can see, is that there was no drug resistance in any of the patients who had virologic failure on any of the
low viral load at baseline.
Yeah, these are very low, typically low viral load. So this degree of viremia is not with resistance. But it's, as you point out, it's really the safety differences that we noted. If you look, for example, at the different safety lines, it's all very low in most of these toxicities. But you can see that in this particular slide, everything looked very reassuring. And overall, you can see the usual efavirenz toxicities that showed up with insomnia and so on, a little bit more than was seen in 744. But it was really the ALT lab toxicities that really caught everybody's eye. As you can see here, just taking a look at grade 1 ALT in the bottom, it appears to be a very important dose-response relationship of 5 to 7 to 21% with grade 1 transaminases, and even, in fact, 2 patients with grade 4 transaminases. Certainly supportive of, I think, looking at this with equal efficacy, that 30 milligrams is perhaps a better dose to go with. Less transaminase increases. There was no evidence of Hy's law, no patients with bilirubin or alk-phos increases, so we were reassured. And while there's a little bit of lipase, there's no clinically symptomatic pancreatitis.
And the other question is, for an individual, how long you have to demonstrate that the drug is safe orally before going to a long-acting formulation. That is always...
Yeah, that was a good point. I think what was noted is, since if you're going to take a long-acting parenteral, if you're having toxicity, you're stuck with the drug. So that he pointed out that their design would be an oral lead-in, make sure it's safe and tolerated, because the half-life of the oral is around 30 to 40 hours. The half-life of the parenteral is somewhere in the order of 30 to 50 days. So they're going to start with the oral, make sure that it's safe, and then if the person is tolerating it, switch to parenteral.
In the context of liver enzyme elevations, I think makes a lot of sense.
A lot of sense. No, it's a very, very smart move in order to do it
because many patients have underlying liver disease. I think we shouldn't forget that.
Absolutely.
Was there a time dependence on the emergence of those ALTs? Did they mostly occur in the first couple of weeks of therapy, or were some of them occurring at later time points?
We weren't given that information, so we'll have to look forward to future presentations on that one. We didn't get the time graph. So there was a little bit more on other new antivirals. I know we're going to get into cenicriviroc in your section, but that was about it for really the new antivirals. There's a new preparation of Valtegra that's in development. There are a couple of other things, but in terms of the clinical kind of next step, this drug probably got the most attention in terms of what's going to start happening for phase 2 and phase 3 of yet another new compound. So thank you very much for that one. I'm going to turn it over to Graham to review adverse events.
Okay, well, as ever, adverse events is a bit of a mixed bag of things. So I was going to start off with cardiovascular and lipids. So what the group at CHIP, the Copenhagen HIV program, I've been trying to do is make a better predictive model for HIV than what the Framingham risk score can by using the DADS data initially as a training data set and then subsequently as a validation data set. So those are the data showed here in the green observed Kaplan-Meier response. And what they've done is create a model that, at least in some circumstances, performs better at predicting risk in an HIV population than a Framingham risk score, so that we have something that is more individualized to our patients, particularly around the effects of antiretroviral drugs and the effects of CD4 count. You can see that the model actually for prediction works. It doesn't matter so much in the non-diabetic patients as it does in the diabetic patients, but I think importantly the people that we're going to be investigating for cardiovascular risk and assessing whether we should give an intervention are those over the age of, say, 40, where you can see that the 2 different models that they have available, shown in red and yellow, are better at predicting the observed event rate than what you would get in a Framingham calculator. And specifically in those populations, the Framingham calculator is underestimating the amount of risk that we're seeing within the DADS cohort. So that calculator will be available on the www.chip.dk website, where you'll be able to find the calculator and then consider using it. Obviously, in the younger individuals, the less than 40 individuals, you're probably not going to be intervening very commonly in those individuals anyway, so the value of your predicting calculator perhaps doesn't matter so much.
Just to remind us, because there are two DAD modes, the reduced and the full model. So the one is with antivirals and the other one is without?
The full model contains the antiretroviral drug contributions, largely listed as PI cumulative exposure and non-nucleoside cumulative exposure, and the abacavir data that they have in that group.
Actually,
they don't
NRTI,
specifically
NRTI,
sorry,
and then abacavir specific.
and then they don't pick out lopinavir and indinavir,
Right.
where the effect was observed, versus atazanavir where an effect wasn't observed. Right. So they just are using all PI cumulative exposure.
Difference between the two models.
No, a little bit. I think there was a nice table that showed that abacavir increased the risk by about 0.5 or 50% increase. But other things certainly are where a lot of the biggest risk is things like smoking and diabetes, as you can see here. The antivirals make a difference, but as you can see, they contribute a small difference depending on the population.
Yeah, and certainly, I offer my patients a statin typically at the age of 50, where you start to see that ramping up of risk. And if you're going to try and prevent risk, you need to start intervening before the events start to occur to try and reduce the risk of those events. So then to look at the effect of drug choices on lipids. So these are some data from the IPREC study, which was of course a healthy volunteer prevention study. So it gives an opportunity to look long term at do specific drugs have anti-lipid effects. Now what we've seen with tenofovir in the healthy volunteer study that our group published over 2 weeks, and intensification studies that have been done with tenofovir in the past where lipids have fallen, and of course in the monotherapy studies where tenofovir has been taken out of a regimen and you see the lipids going up. So we already knew that tenofovir had an anti-lipid effect.
Was seen in Gardel too.
Yes. That's right. And what one sees here is that for those individuals in IPREX who took tenofovir, and specifically those who took the tenofovir within the study, because they also showed a subset of people where they couldn't even find any tenofovir, and not surprisingly, when you can't find the drug, you can't find an effect. Right. But for those people who were taking tenofovir, there was a marked lipid reduction effect of around 10% in total cholesterol, or 10 milligrams per deciliter, and around 8 milligrams per deciliter that was mostly accounted for by LDL. Now, there did appear to be an effect in terms of waning of that response over time, for which there wasn't a particularly clear explanation. And of course, no one's been able to investigate the mechanism by which this occurs, but it's an intriguing observation. I think when we look at the TAF formulation of tenofovir, where you're getting lower exposure of tenofovir, there wasn't the same lipid-lowering effect, suggesting it's certainly a dose-dependent effect. And so that may reflect some waning of adherence over time. So cenicriviroc is a CCR5 active agent which has some CCR2 off-target activity, which may be of interest in terms of reducing monocyte activation, and so it's potentially a variation on the class that we have at the present time represented by maraviroc. The study that was presented here was their phase 2b results. It was complicated by the fact that there were a lot of treatment withdrawals within the study because they had a complicated dosing regimen. So even though the comparator group in the study was Truvada efavirenz, everyone in the study was taking 6 pills and a BID dosing schedule because of the blinding in the study. Overall the efficacy of cenicriviroc looked pretty comparable to efavirenz, given the limitations of what the design of the study were able to show. What's very clear with maraviroc and also here with cenicriviroc is that these drugs are lipid benign, and when of course you combine them on a Truvada background, you get the Truvada lipid lowering effect with the cenicriviroc. So again, you see a neutral impact on HDL and a reduction in LDL and total cholesterol, less impressive effects with regards to triglycerides. Now in the STAR study that you presented, Cal, we also see a differentiation in the observed effects, in this case of drugs within the non-nucleoside class, where we've got, of course, drugs that work in the same way but have structural dissimilarity to each other. And what we know with efavirenz is that we see a lipid increase with efavirenz, and that lipid increase is a mixture of LDL and HDL. Of course, in our HIV patients, we often see HDL as the important lipid deficit before we start. So for some individuals, that's an important thing to correct upwards in a meaningful way. But ultimately, when we think about how many people are over a particular threshold that you might use, say, from the National Cholesterol Education Program, you don't want to be pushing more people above that threshold. So what we see with the use of the Eviplera Complera single tablet is a very neutral impact. If anything, the triglycerides go down very marginally, probably because triglycerides go up as HIV disease advances a little bit. You've got that correction in HDL, which is probably a restoration to health effect occurring there, and very other little effect, whereas with the efavirenz we see that characteristic lipid profile. So when you look at cutoffs, how many people went above a particular NSEP threshold, you see that happening more often in the efavirenz arm with regards to the key atherogenic lipids in that regard.
Did increase more, absolutely.
So we're getting a bit of idea that you may be able to differentiate with products in this regard. With Flamingo, we didn't have much detail about lipids, unfortunately, because we'd like to know a little bit more about the lipid effects of the different agents. What they reported was simply grade 3 values, where there was a couple more lipid events in the darunavir arm relative to the dolutegravir arm, and then this creatinine kinase issue that's been seen a little bit with dolutegravir and was also seen in some of the studies with raltegravir. So whether this is perhaps not a class effect, but whether it's something that is characteristic.
At least in the label.
It's in the label, and that these effects, it's unclear. They're not associated with symptomatic muscle problems, but there are clearly episodes of these grade 2, 3 creatinine kinase elevations. And then, of course, we have the renal effect with dolutegravir that we know arises through the OCT2 transporter in the kidney.
The renal is different if the nucleosides are Qibexa or Truvada.
A little bit, marginally.
Very marginally.
Very marginal.
Very marginal, yes.
So, that's a few emergent stories in that regard. So that shifts us into the world of GFR. So we've got compounds where we're inhibiting the MATE1 transporter, such as ritonavir and cobicistat, and we've got compounds that are inhibiting the basolaterally located OCT2 transporter, and that's rilpivirine and dolutegravir. Now, rilpivirine is clearly a much weaker inhibitor of that enzyme, but we are recognising in studies as we see more comparative information, and here this is all with Truvada, that there is a little bit of a blip downwards in the first couple of weeks as you introduce rilpivirine. The effect is about half the magnitude of what one sees with cobicistat or with dolutegravir, but it's something that I think physicians need to be aware of. And then, of course, from the week 4 time point in this case, also data reported with week 2 time points with cobicistat, is that you effectively see a flat line, that there is no meaningful change in the estimated GFR over time.
Exactly. And again, we'll just, hopefully, I assume people will understand this is estimated GFR. Actual GFR is unchanged by these molecules to the extent that that's been queried further, that this is a change in kind of creatinine measurements and so on. We've talked about that for a few years now.
And I think that it's important that, when you've got a patient who has a complicated medical history, that you're able to communicate this information to other healthcare professionals who are involved, who may misinterpret a change in renal function when you change somebody's medication around as something that is an adverse experience rather than an enzymatic experience. It's enzymatic rather than problematic.
Right, exactly.
Okay, STAR requested GFR about 50, right, as inclusion criteria, in contrast with the quad study that requested 70.
There are no label restrictions around glomerular filtration with rilpivirine.
Other than tenofovir, which is greater than 50, exactly. Right.
So these are from the 103 data, so comparing the L-vitegravir cobicistat combination tablet with the FTC, with Truvada plus atazanavir, ritonavir. Here really showing the ritonavir effect as well as the cobicistat effect, that you see about a 10-point change with your ritonavir, about a 13-point change with the cobicistat. So that there's not such a big difference. And as the interquartile ranges here show, there is no change after that week 2 time point, so the second, or the week 4 time point. So the second chart there is the week 4 values, and that's really a flat line over time from that, and that there was no new proximal renal tubular dysfunction events in terms of phosphate loss or in terms of normoglycemic glycosuria that emerged after the early time points.
But have you seen data about beta-2 microglobulin or
I've not seen tubular marker data thus far.
We haven't seen those.
No, just the standard proteinuria, normal glycemic glycosuria, and then hypophosphatemia. Kind of at least in the U.S., the standard definitions for Fanconi. Yeah. But we haven't seen the other markers. Yeah, that's coming, I think, in subsequent studies. So yeah, this study actually had no evidence of Fanconi in any of the patients for the entire 3 years. This was a nice, reassuring data set.
So we're always interested in drug interactions, and often we pick those things up in clinical practice unexpectedly. And these were data from the Frankfurt clinic that Marcus Bickel presented, where they noticed a couple of individuals who'd been given diclofenac predominantly for back pain, who'd developed acute renal changes, either in terms of phosphatemia, normoglycemic glycosuria, or a marked increase in proteinuria. And fairly universally, that phenomenon was in people who were taking tenofovir at the same time. Now, interestingly, he commented that they didn't see that in people taking ibuprofen, as an example. So, you know, whether this is a particular interaction that is occurring between diclofenac and tenofovir DF, or whether it's entirely, you know, that a lot of patients are taking tenofovir and then you happen to give them diclofenac, because we know in the general population that diclofenac can also cause renal disturbances.
EMA has just withdrawn diclofenac.
Really?
Yeah.
Oh, that's very interesting. That has not happened in the U.S. that I'm aware of. Yeah. That's interesting.
Yes.
Okay.
Yeah, but I think the interesting thing
because
is
of because of higher cardiovascular
cardiovascular
risk. That is perfectly timed because it was happened 2 weeks ago.
Interesting.
But a lot of people now, because they're aging, develop joint pain of all sort, and they're increasingly seeing physicians from other disciplines. And there are really two problems, right? It's the steroidal anti-inflammatory drugs, non-steroidal anti-inflammatory drugs, and the steroids themselves, which interact with a lot of our drugs. And we see a lot of complications, and you know, it's something we don't talk so much about, but it's really something we need to implement better in our care, because, you know, these increasing issues really lead to some significant drug interactions, which is nicely shown here.
It's really something to watch out for in clinical practice. You know, it's not clear that it's a tenofovir problem more than it's a diclofenac problem, but particularly as when they didn't see the problems with other anti-inflammatories that they were using. The Swiss cohort looked at patients within their cohort who were on tenofovir-based regimens, either with a non-nucleoside or a PI, and they looked at what was happening to the GFR over time. So it's something that, you know, we want to have a look at, you know, that so-called real-world experience of what's going on in what's a very well-collected cohort study. And so in the two lines that one can see here, the solid line for the nucleoside, for the non-nucleosides, and the dotted line for the boosted protease inhibitors, is that there appears to be some drift down in eGFR over time in people taking tenofovir. But you can also see by the background of pointillism there that there is an incredible variation in these phenomenon within individuals.
Yeah, it's hard to see that line in those dots, but
exactly. And so when they looked at then people who switched away from tenofovir-based regimens, there didn't seem to be much change in those individuals who were on the PI backgrounds, but there appeared to be some trend for recovery in those individuals who were on the non-nucleoside group. We did see some data at the Kuala Lumpur conference from a British Columbian cohort, where there'd also been this recovery predominantly in people taking non-nucleosides, but also PIs after switching. The effect appears pretty modest, and it makes you wonder, if you're removing the tenofovir on the PI patients and it's not getting better, whether that's really anything to do with tenofovir at all.
Or is the ritonavir inhibiting the transporter, right?
Exactly. Yep.
So, you know, people are trying to tease apart whether there's really an effect or not an effect, and I'm not sure that that cohort data is big enough to answer the question. Certainly underlines that marked declines in GFR are pretty uncommon, because as you can see, the cutoff they used on the graph was a GFR of 60, which tends to be the level we start getting interested.
Right.
So then if we shift over to bone events, here from the 103 study, so now comparing L-vitegravir cobicistat with atazanavir ritonavir, each with Truvada. We know Truvada-based regimens are always associated with a greater decline in bone mineral density than non-Truvada-based regimens. Is there a difference between these different partnerings? Well, the answer is not statistically significant with regards to hip, but at week 144 there are some statistical differences with regards to spine BMD that suggests that the PI-based regimen may have a little greater retention of the initial bone insult that occurs relative to the later group, so you're getting that regression back to baseline.
What's
Now,
the best explanation of that?
Well, one possibility is that when you look at hip BMD, you're predominantly capturing a bone which is cortical in its predominant bone mineral density, whereas the spine has a much lesser cortical component and a greater trabecular component. So it may be that there are differences going on in terms of the remodeling of cortical versus trabecular bone as a potential explanation.
This was done in a subset of patients. It was not a randomized sample of the patients.
No, it was site-specific evaluation.
And in comparison between TAF and the quad with TAF.
When they've used the TAF formulation over the limited data that we've seen so far, there was a much lesser effect, and that TAF seems to behave more like non-TDF-based regimens do in that regard.
In the quad control with the tenofovir, the coming back to baseline was seen, or it was 24 weeks?
In other studies, it's not unusual to see that regression back to baseline, and the effect is often greater in the spine than it is in the hip.
Yeah, the TAF, we only have week 48, so it would be kind of premature to see, because you can see it.
But for example, in 5202, that phenomenon was observed.
Yeah, absolutely.
So the PROGRESS study is a second-line study looking at lopinavir with raltegravir or lopinavir with Truvada.
Naive patients.
Sorry, it's in naive patients.
One,
And in this case, so you've got a Truvada sparing regimen versus a nuke sparing regimen, and that they've previously published some of the data that the bone mineral density goes down a bit more. Here they were underlining this effect in terms of looking what was the proportion of subjects who had a more than 5% decline in baseline. So a bit like what was going on with lipodystrophy a few years ago, where people were saying, you know, a 10% decline from baseline in lymph fat or a 20% decline. This was an idea that Todd Brown had about how many people lost what appears to be a kind of meaningful amount of bone mineral density. These are not necessarily saying how many people developed osteopenia or osteoporosis, it's how many people lost 5%. And you can see the nuke sparing regimen has a lesser effect on impacting bone than the Truvada-based regimen. So the interest in bone mineral density, of course, gets down to, does bone mineral density matter to fracture? So when we look at osteoporosis in an HIV population versus an HIV negative population that is matched, so these are Dutch patients, the HIV patients are coming from the AGE-IV cohort that Peter Rice has set up, and you can see for all of the different regions that were assessed for bone mineral density, there is a slight excess of osteopenia and osteoporosis in the HIV population. But then when they looked at traditional risk factors for that and adjusted for two key characteristics, body mass index and smoking, the effect of HIV went away, underlining that really the low bone mineral density may be more an issue of a higher prevalence of traditional risk factors amongst the HIV population rather than it being an HIV or specific drug effect on bone. And specifically here they didn't find an impact on tenofovir-based regimens and the prevalence of osteopenia or osteoporosis within their cohort. Now then there was these data which are the first to see this in the setting of HIV, and you know, to a certain extent you think this is, it's stating the obvious, but this was two cohorts in the United States, a high prevalence of osteopenia, over a third of patients osteopenic, but a small number who are osteoporotic. The risk factors for low BMD, age, lower CD4 nadir, history of fracture, and for some reason men who have sex with men came up as a risk factor for that for reasons I don't know. And then they had some fractures in the study, 98 fractures out of 5,000 patient years of follow-up. The fractures were rib, sternum, hand, foot, wrist. So not necessarily the same ones that we would see in an elderly population. Right. And the risk factors for fracture, as distinct from low bone mineral density, were age again, smoking, history of hepatitis C, and low bone mineral density. So now we're seeing that low bone mineral density actually matters in our HIV population for having more fracture events. So it underlines that we should be monitoring bone mineral density in our patients, because bone mineral density in HIV means something to fracture risk in our patients. And that the fractures that are occurring in our patients, here we've got a reasonably young cohort, 42 is the average age, and you're getting fractures at non-traditional aging sites. I suppose the wrist is a traditional site, but you don't normally think about hand and foot and rib fractures being such a common thing. So low bone mineral density in HIV means something to our population. And the hazard ratio that being osteoporotic more than tripled your chances of having a fracture within the population. And that's obviously something that we can attempt to address by intervening with bisphosphonates. So the last thing I wanted to finish on was something that's very interesting in our clinic. We are interested in the idea of forgiveness within treatment. How late can you be with a dose before you start to reach a critical exposure that may be getting a drug falling below the minimum effective concentration of a drug? So we got a group of healthy volunteers, 18 individuals, that we dosed with Eviplera Complera for 14 days, and so that they were at steady state, and then we stopped their therapy and looked at how long did it take to fall below target. And one can see at the 24-hour time point, there was a couple of individuals who were just a whisker below the target level, but they were very close to the target level you'd want to achieve. So for those individuals, there wasn't so much forgiveness. But if you look at the range of exposure that people are seeing, there's a threefold range of exposure, and more than half of the subjects were still well above the rilpivirine target exposure 48 hours later. So in fact, for the majority of individuals who take a rilpivirine-based combination, there's an incredible amount of forgiveness in the dose timing accuracy of that, because I think often, in a way, what we saw in the swing study was that people's lives were getting controlled by this same time of day with a meal thing. Right. And I think this underlines that for many individuals, the same time of day with a meal actually is not going to matter at all, because you've got a drug with a long half-life.
Did they have a standardized meal? Or?
They were observed dosing with a standardized meal within our pharmacokinetic
It was a steady state.
They were at steady state and then stopping from steady state.
That's very nice work.
It's it's interesting to get the idea that forgiveness is built into this combination, but the forgiveness is going to vary from one individual to another, and what we need to do is try and do a bit more work to understand who are those individuals who have got the low exposures at steady state versus those who have got the optimal. So this drug
depends a lot on the gastric pH absorption. There is any caution extrapolating this from healthy volunteers to HIV-infected patients. I remember in the past...
Absolutely, that achlorhydria is more common amongst HIV patients.
I think that was very advanced patients.
Very advanced patients,
exactly.
If I remember, there was
very low
times,
CD4 association.
Yeah,
so much here.
We don't know what the target should be in healthy volunteers, but if I remember rightly from the development program with rilpivirine, actually the pharmacokinetics didn't differ a lot between the phase 2 study and the developmental study.
That's good, interesting work. Thank you for that. So, Jürgen, we've got your usual 20 minutes in which we get to review the entire hepatitis field, so we look forward to it.
All right, so let's move to hepatitis, and I have to say, obviously, with the new drugs around, there's a lot of new presentations, and it was exciting because we saw at EACS results from some of the new compounds which are expected to be licensed next year, 2 new second-wave hepatitis C protease inhibitors, feldapivir and simepravir, with SVR rates, so I think that was sort of exciting. But I want to start really with a study which is a collaborative effort between 12 German sites and 8 Spanish sites, really trying to get a large number of patients who were either treated with boceprevir, telaprevir, and these included a whole range of different patients. And as you can see from the baseline characteristics, the smallest proportion of patients, 22%, were naive, so never had been treated before for hepatitis C, and the majority had been previously treated, and of those, 40% were non-responders. And remember, those are the ones who are tough to treat. The amount of patients who had a non-CC, so a good interferon sensitivity, was high, so very unlikely to respond. And I think even more importantly, it really reflects the real-life cohort, with 42% having F4 fibrosis, which corresponds to cirrhosis. So we have a lot of non-responders, cirrhotic patients. So clearly a challenge for the treatment with triple therapy containing either telaprevir, which the majority of patients were on, or boceprevir. Now, if you look at this interim analysis, which only looks at treatment undetectability at week 24, you can see that with 75%, this is surprisingly high for a patient population, which is obviously much more difficult to treat than what has been published in the 2 pilot trials, which were both published this year for boceprevir and tenofovir in treatment-naive patients where cirrhotics were on average not included. So obviously with these pre-treated patients, it really looks pretty good. And I think what was very reassuring that even in the toughest group, the non-responders, you can see that at week 24, 65% were undetectable, so clearly much better than what we have seen in any previous study. And then also looking at the differentiation between those who had cirrhosis at baseline, I think very reassuring to see that although that was lower, it still was much higher than you may have anticipated. But again, I think it's also fair to say this is week 24. Remember that in the monoinfection trial, the CUPIC, we saw pretty good early treatment responses in the early time points, but then when treatment was stopped, the SVR rates, SVR12 was actually much lower, and only around 40% of patients respond favorably. And this was, again, a cohort of patients who were cirrhotic and had a previous unfavorable outcome after a dual therapy. So I think we have to acknowledge that there are obviously at least some hurdles here to overcome, but clearly much better than we probably would have anticipated. Now, looking at the adverse events, I think it's important to say that these triple therapies in the current forms, unfortunately, are associated with quite a burden of adverse events, predominantly around bone marrow toxicity, mostly induced through anemia through ribavirin, and then obviously interferon causes leukopenia and thrombocytopenia, and really a large number of patients had anemia in this trial. There were skin rashes, but so far, in this trial at least, none led to discontinuation, and there was a fair amount of CNS symptoms, which we typically find under interferon treatment.
This study also used tenofovir for 12 weeks, and boceprevir was continued for the entire
so
time.
It was followed the label, which was basically 12 weeks, and then the 4-week induction for boceprevir treatment. And then, unfortunately, 1 patient died of liver decompensation, and we know very well from the CUPIC trial in monoinfection that there is an increased risk in this setting of baseline cirrhosis. And in that study, they showed that if your albumin as a marker of liver synthesis is decreased below 35 milligram per deciliter, and in conjunction with a very low platelet count below 100,000, you are at increased risk for these hepatic decompensation. In the setting of hepatic decompensation, you're at increased risk for SBP, sepsis, and then the patients usually die from that. And that is a limitation, and clearly this is something which is very strongly interferon related. That has already been described for dual therapy, that if you have sort of more end-stage liver disease, the risk for bacterial infections is high because patients have a low white blood cell count to start with. And that's important because this may all change when we get interferon-free regimens where interferon is not in the play, and probably the risk for such infections becomes much lower.
What antiretrovirals were they taking?
So the patients were, the majority, around 50%, were on raltegravir, and the next was boosted atazanavir, and then the third most common used agent was efavirenz, and you would think that is sort of what is currently recommended on the basis of the drug-drug interactions with tenofovir and boceprevir. So the boceprevir patients were mostly on raltegravir, and the other ones also had the option of boosted atazanavir.
And mostly Truvada as the background,
Yeah, and mostly Truvada.
Okay.
So
sorry, just one last question. Was there any BD dosing of the tenofovir, or it was all 3 times a day?
So this is still from the time where TID was used. In the guidelines, in the updated version, we did not recommend BID because of the drug interactions. You can't really necessarily transfer 1-to-1. So in the lack of any data, I think it's difficult to recommend that. Although in clinical practice, quite a number of physicians feel comfortable enough with the monoinfection data to dose tenofovir BID, and I think it's an option. But again, this is in the lack of any drug interaction data, and because there were all these unforeseeable interactions, it's a little bit difficult to transfer that 1-to-1. Now, one of the other 2 studies I want to present is a study which is called START-VERSO, and this is the registrational co-infection trial which Boehringer put up, where they're investigating their second wave hepatitis C protease inhibitor, feldaprevir, and the big difference to boceprevir and tenofovir is this is a once daily protease inhibitor, so it's going to lead to a much easier administration. In monoinfection, also associated with a different adverse event profile, so offering some obvious advantages. Now, obviously, the first question always is, are there significant drug interactions? Yes, feldaprevir is also metabolized by the cytochrome P450 system, so there are some interactions. So the design is a little bit complicated because depending on which HIV therapy you were on, you were either allocated to a dosage or randomized. So if you were on raltegravir or had no HIV treatment, you were randomized to 120 or 240 milligrams. If you were on an NNRTI, which causes induction, you were going to go for the higher dosage of fludarabavir. If you were on a boosted protease inhibitor, you were going to go on the lower dosage because of the interaction. It's important to note that this is the first study where boosted darunavir was allowed as a background HIV therapy. Remember, this is not possible for boceprevir, not possible for telaprevir. Now, since patients who have accumulated resistance are frequently in a salvage regimen, including darunavir, and since these are actually more likely patients who have a long history of hepatitis C and more likely to have advanced liver disease, this is obviously a great addition in our chances of treating patients. So the patients in Arm A received 120 milligrams of fludarabavir plus PEG and riba for 24 weeks, and if they achieved early treatment success, which was defined as being undetectable below 25 international units at week 4 and undetectable at week 8, then they qualified for randomization to shorter or longer PEG interferon treatment. So this looked also at different durations of treatment, adding a tail of PEG riba or stopping at week 24. Remember that currently the guidelines are recommending 48 weeks of treatment for triple therapy in the lack of any response-guided therapy approach with telaprevir boceprevir, which has been published in a full data set yet. So this would obviously allow to treat our patients, if they respond favorably at the beginning, for 24 weeks, which is, I think, a huge difference. And then Arm B was 12 weeks of the higher dose with PEG riba, and then patients were randomized either to maintaining the high dose or already being put on the maintenance therapy, and then again, the same thing, if they had early treatment success, were randomized to stop or continue therapy. Now, looking at the HIV and hepatitis C specific baseline characteristics, I think it's important to note that the majority was genotype 1A. So again, this is a protease inhibitor which is also active against other genotypes, but in this study only genotype 1 patients were allowed to be included. Most of the patients were highly viremic, and it only included treatment naive patients, which was the majority, around 80%, and then 20% being relapsers. With regards to HIV disease characteristics, there was quite a number of patients, obviously, on a boosted protease inhibitor, some patients on efavirenz in the corresponding dose arms, and then the highest number of patients on raltegravir-based therapy, as we're quite familiar with, a very good CD4 count, and most of the patients being undetectable, reflecting that patients were well controlled for HIV disease. Now, if you look at the overall patient population, and we're talking here of SVR4, so stopping therapy 4 weeks later, treatment success rates were determined. So obviously we also want to follow up a little bit longer, but this has been shown in monoinfection at least to work pretty well as a prediction marker. And you can see 74% of the patients were cured. And so that's obviously quite exciting in this patient population, and it was pretty much similar between the different dose arms. And if you then, and what I forgot to say is that there was a proportion of patients who were cirrhotic in this trial as well. And so obviously the question is, do we have different response rates in this patient population of naive and relapsers? If you look at the cirrhosis at baseline, there was actually no difference, which is extremely reassuring. If you look at whether naive or relapsers differentiated in their cure rates, relapsers did better. That is what we know from all trials in hepatitis. Those are the ones who just need that little extra activity. They were already interferon sensitive, got negative, but then didn't have enough activity to maintain that suppression. And then if you look at the amount of patients who achieved an early treatment response or early treatment success, you can see that this was really the majority of patients, which again I think is extremely reassuring, because it tells you that most of the patients actually qualify for shorter treatment durations. If you look at the overall summary of adverse events, I think it's fair to say that there were very few adverse events leading to discontinuation of fludarabavir only, so at least the tolerability looked pretty good. There was one death in the trial, but otherwise it looked very good. Moving on to the last trial I want to present, and that is the other second wave hepatitis C protease inhibitor, symmeprevir. which has been presented also at this meeting as an oral in the hepatitis session. Now, this trial included treatment-naive and prior relapsers, but also partial responders and null responders. So they also looked at the more unfavorable previous treatment outcome patient population. And again, they looked at a response-guided therapy approach. So patients who were naive or relapse qualified for shorter treatment durations depending on early treatment success. And patients who per se were believed to be a little bit more difficult to treat, partial responders, null responders, and the cirrhotic patients, which fortunately were also included into this trial, were treated for 12 weeks with simepivir, 150 milligram pegriba, and then there was a longer tail of 36 weeks, adding up to week 48 when treatment was stopped with pegriba. Now, if you look at the baseline demographics in this patient population, again, only around 30% of the patients had the favorable CC genotype, so most of them had the unfavorable one. There was a very high median hepatitis C viral load, which is typical and the hallmark of hepatitis C and HIV. Again, a higher distribution of the 1A, which is commonly more difficult to treat, and at least 12% of patients had a cirrhosis, and you can see that 20% had F3, F4, so also at least including some patients which are presumably more difficult to treat, and remember there were also some non-responders in this trial. HIV-wise, patients were well controlled and had a high average median CD4 count, and looking at the background therapy, it's evident that boosted PIs were not allowed into this trial because of drug interactions, so at least that is sort of a limitation that you can't use all background antivirals. Most of the patients were on raltegravir and some were on rilpivirine, so at least there are some options.
And is that because the interaction studies haven't been done, or is
No,
it because the interactions
there are interactions, yeah.
Problematic?
So if you look at the primary endpoint, and this is already going or reaching out to SVR12, so this is full recognized in the context of an interferon-containing regimen as the primary endpoint. And you can see, again, 74% response rate. That's very comparable to mono-infected patients, and obviously quite exciting because, you know, for genotype 1, difficult to treat, and clearly there are some differences. Again, relapsers is the ideal group, almost 90% of patients responding. It sort of goes down with more unfavorable previous treatment responses to dual therapy, 57% with prior null responders, but clearly much better than anything what we've seen in the past, and clearly offering quite some prospects for the near future. Remember that feldapivir and simepivir are expected to be licensed next year, so obviously that is of quite some excitement. Remember also there are other drugs which were not presented at this conference, but it's fair enough to say that the next to be licensed DA will be sofosbuvir, which also will have some co-infection data being presented at AASLD, so we will have a wealth of co-infection data coming through shortly. Looking at the response-guided therapy, how many patients qualify for response-guided therapy, you can see that almost 90% of the patients were eligible for 24 weeks of treatment, and obviously that is extremely important because it means that for the majority we're really going to dramatically shorten treatment durations, which is something we've been waiting for so long. And this was true for naive and relapsers altogether. Looking at the adverse events, we do have a relatively good tolerability. It's all driven by the typical interferon ribavirin adverse events we know from dual therapy, and the safety profile overall was very much comparable to what they had seen in mono-infected patients, so nothing special which really sticked out here. A little bit of photosensitivity and increased bilirubin, but otherwise relatively well tolerated, and nothing new other than the typical ribavirin and interferon-related adverse events.
Great. So we've got a few minutes remaining, and I wonder if there are any studies that any of you saw that we haven't covered here, or discussions around the hepatitis?
I think Ryan mentioned tenecruviroc, and it's interesting that the development of tenecruviroc is going to be, when they presented the trial, is as a substitution of one of the nucleosides and not a third drug. Right. I found that it's been a while since we've seen that type of development.
Right. I think that's part of the interest, that we're getting some generic compounds like 3cc becoming available, and that people are interested in, can we start co-formulating with, as it were, chimeras of generic and still on patent medications, and then I think we'll see an expansion of those.
Speaking of tenecruviroc, I understand there was some interesting liver data here?
Yeah, I mean, I think obviously in the context of a chemokine receptor blocker, the big question is, what is that going to mean in immune modulation? And in that study, they looked at inflammation markers, which actually changed. Obviously, adding the inhibition of CCR2 may add something on top of what we have seen with Maraviroc. Remember that also with Maraviroc, we already had some data suggesting that potentially fibrosis regression could occur in patients, and there are some ongoing trials investigating that. I presented a poster just looking at the hepatic safety of Maraviroc in the modern, no, not the modern, different name trial, sorry. But, and we had no hepatic safety signal of concern, but the real exciting question is, are we going to see regression of fibrosis? And that data has not yet been analyzed. But they also reported that they will be presenting data at AASLD, which will look at some effects in patients with NASH, where potential...
Mice with NASH.
Yeah.
Are they not, rather than patients?
Yeah, that's true. It's animal data, but it really suggests that they saw significant changes in the fat content. And since we don't really have anything in humans which we can use for treating NASH very successfully, the animal data at least is encouraging and suggests that this may be a different pathway to go.
That's right, they saw transaminases go down in the mice and various other markers. The problem is there isn't really a perfect NASH marker in blood, is there, that we can look at and say...
It's very difficult to say. It really requires histologic examination. You can measure fat content in the liver through some imaging, MRI spectroscopy, for example, not in the rats, but in humans. And I think that there's a lot of interest, though, because NASH is sort of becoming the leading cause of liver transplantation, and so I think that's an area of interest.
Yep, that's true.
And there was a poster about the interaction between rilpivirine and metformin, right? That's also is something practical, right?
Yeah, so both of the US label for dolutegravir and for the Stribild combination tablet have warnings about metformin, because metformin is one of the drugs that we know is a substrate for both the organic cation transporter 2 and for the MATE1. And so rilpivirine inhibiting OCT2 in a weak way was important to investigate, and it appeared that there didn't appear to be an important interaction with metformin, which is reassuring, because one of the attractive things, as Cal showed, is that it's a metabolically modest drug, and therefore it's quite attractive for those people who are appropriate for that compound and are diabetic.
Did you want to comment then on how concerned you are about dolutegravir with metformin, or I guess the elbiteragravir, because the effect, as I understand it, while it may be there, I mean, certainly there's a good therapeutic toxic ratio on metformin use. Yeah,
there's a label warning, and I think that at the present time all you would do is be cautious about your metformin initiation dose, and that you would escalate slowly. But clearly the interaction study needs to be done. The assumption is that there'll be a small increase in metformin levels, so routinely we'd start at 500 twice a day, say, and then go up gradually. So I don't think that it would necessarily change our practice about the way in which we use metformin. It's just another thing where we need to communicate to the diabetologist that probably if you're thinking of going up to 1,000 3 times a day, which is the maximum dose of metformin, you probably don't go that far.
Well, thank you to all three of you for a great review of another exciting week. As you can hopefully tell, we had a lot of information here, some brand new data, some guidelines, lots of discussion in the halls to make sense of these data. So we appreciate you joining us for another CME Internet Symposium reviewing the European AIDS Conference. We look forward to seeing you again in another Internet Symposium.
This concludes our web symposium entitled ARV Therapies and Therapeutic Strategies, which has been brought to you from the 14th European AIDS Conference in Brussels, Belgium. To receive CME credit for completing this activity, please follow the on-screen instructions or go to www.viraled.com/EACS 2013 for more information. For more programming information, including weekly HIV Grand Rounds from the University of Pennsylvania, please visit www.viraled.com. Thank you for your participation.